Yeah,
We
Icon
we
is,
are
yeah.
live. We are live.
Yeah, one second. Let him just check one. Yeah, go full screen, Icon. Yeah, you're fine.
Okay, it's fine.
Yeah, it's fine. Please log
Thank
out.
you.
Yeah, we start. Yeah.
We are live. Ayush, we are live.
Go live.
Yeah, we are live. We are live.
Okay. So, good morning, good afternoon, good evening, no matter where you are. Welcome to another interesting session in the series of WIROC webinars. We all know WIROC is one of the biggest event orthopedic conference which happens in India. It has been there for many years, and this time we are doing a series of webinar. In this series, what we have today is the future of minimally invasive spine surgery, and we have all the bright stars from India and abroad who will sort of allow us to look what to do when it comes to MIS surgery. To start the session, we have Dr. Arvind Kulkarni, who is also the chair for this session. Another big name and another giant in MIS surgery, Dr. Vishal Pese-Tiwar, is the co-chair. I am Dr. Ayush Sharma. I am just the convener for this, and we have a brilliant panel from Dr. Aikov, who is from Georgia. He is a neurosurgeon by profession, but again, a very well-known name in terms of MIS surgery. Sambhav is our local Mumbai boy who is known for his work in endoscopic spine surgery. Guru Raj is from Indian Spine Injury Center. He's known for his tubular work, for his work in robotic spine surgery. And we all know Abhijit Pawar. He is again a well-known name in Mumbai and across India and across globe. And again, he is a hell of a guy when it comes to tubes, MIS and everything. So not to take any further, I will call upon the Dr. Arvind Kulkarni to talk about and start with the introduction to MIS. It's not just about the skin incision. It's more than just skin incision. He will give a brief insight why it is important to understand what is the principle of MIS, how it matters to the patient, how it matters to the surgeon. Over to you, Dr. Anvil Kulkarni.
Yeah, at the outset, can you see my slides?
Yeah, we can see.
So at the outset, let me thank Dr. Ayush and Dr. Dheeraj for inviting me. So dear friends, chairpersons, the panelists. So I'll not waste much of time. I'll dive into the talk. I will try to attract your attention to the benefits of MIS using some case examples. So that will be more awakening than a didactic lecture. So this is a heavenly body having a right-sided, left-sided disc herniation. For him, it's a small, ant in his body which is causing so much havoc. He has severe left leg pain of a considerable duration, scared of surgery, not ready for any kind of big surgeries. Comes to us. It takes about not more than 30 minutes to get this tube in, which is a 40 millimeter tube that goes in deep right onto his L45 level, gets the disc out, is walking majestically within about 3 hours following surgery. Just like the size of the disc, this is also like a fly on his back. You can hardly notice the scar. All these scars, they are stretched out. All these incisions are stretched out when the patient is prone. But once the patient stands, they all contract, and after some time, they are hardly visible. So this is a boon for such patients. And this is another, so disc herniation forms a prominent part of our practice as a spine surgeon who is into bread and butter practice. So now comes the most commonest diagnosis that we face in our day-to-day practice. Most of our practice is degenerative, and almost 80%, and about 60% of degenerative practice is spinal stenosis. And if you can deliver your goods with minimal access, there's no excitement beyond that. So this is a very, very tight canal, extremely tight canal. The dura is squeezed between the layers of phlegm on either sides, and the whole thing is pulled out. The whole canal is freed using minimal access, again using a very small 16 mm tube. So that is the kind of excitement that MIS creates and the kind of recovery these patients are a baggage of comorbidities, and to see the smile on their face and see them walking the very evening of surgery is very, very rewarding. There's no drains coming out, there's no catheter, just one shot of antibiotic pre-op and post-op, and here they are going home very next day. This is another elderly patient, middle-aged patient, sorry, who has 3-level stenosis with instability, who needed 3-level of decompression fusion. So she undergoes a 3-level decompression fusion, stenosis at 3 levels, listhesis at lower level. So this is the size of the scar. So, and look at this particular patient. He has double pathology. So there is a disc herniation at L4-5, and the L4-5 disc has dropped down. At the same time, patient has a lytic listhesis. So through the axilla of through the axilla at L5-S1 level, we could remove this particular disc herniation which had come down, and through the same channel, we could do an interbody fusion at that particular level. So dealing with two pathologies through minimal access. So the the disc herniation was managed by tilting the tube slightly upwards and pulling out that fragment, and by tilting the tube down, we could accomplish a TLIF at that particular level. This is a very interesting case, which is this is a terrific combination of navigation and minimal access. This patient had an osteoma seated deep into the right-sided S1 pedicle. It is very difficult to get XYZ coordinates if you're doing an open surgery. So using navigation, we could localize the lesion through the tube. We were right bang on the target thanks to navigation. And thanks to the tube, we could focus straight onto the path of the lesion. So, so this is a navigated drill. Quite an exciting surgery, going straight all the way till the nidus of the osteoma, emptying it and running navigation again to confirm complete excision of this particular lesion as seen here. Very, very rewarding. Doesn't take more than 45 minutes to do this kind of a procedure. Just imagine doing this open, you would be lost in finding out where the lesion is. Another patient, elderly lady with a huge burden of comorbidities, extremely high risk for any kind of open surgery. So 3-level stenosis, you can see here 4-5, 3-4, and 5-1, all dealt with a single incision by just tilting the tube above and below. So that is done through a very small incision. It's about 18 millimeters, but just angling the tube. One of the prerequisites for this kind of a procedure is the patient has to have a lordotic canal, and you should take advantage of this lordosis when you're positioning the patient, because that is how you can target and angulate the tube in three directions, three trajectories. And then comes the benefit of MIS, wherein you can do a discectomy using using local anesthesia. So this patient underwent the discectomy. Uh, I was talking to her all the time when we did this. This is an interlaminar discectomy done through the tube. So you can see she's just on oxygen mask and listening to music. So these kind of procedures lay foundation for eras. Another significant component of MIS is stabilization. So this elderly lady, again, rich with comorbidities, she has undergone a posterior destructive laminectomy years back, never got out of the bed. The wound healed with secondary intention after a plastic intervention. I mean, she developed a post-laminectomy instability. So you can see this facet effusion here. This is all fluid here. You can imagine the amount of pain that this patient would be in terms of back as well as leg. Even turning in the bed was painful for this lady. And can anyone imagine going through the same scar and stabilizing this particular patient? All that she needed was stabilization. So this scar was left unattended. So through a small port on the left side, we introduce this tube, and through that we did an interbody fusion. And the same hole was used to put guide wires and pedicle screws, percutaneous pedicle screws on the ipsilateral side, and it was stabilized on the opposite side using these small two keyholes through which again percutaneous pedicle screws were introduced and a rod was placed. She got up very next day after surgery, extremely delighted, extremely happy. Stretching it far, we have been able to tame grade 4 spondylolisthesis, including a spondylolytic listhesis using MIS technique. It's an advantage in these particular cases where you need a very perfect trajectory, very good trajectory, good big diameter pedicle screws in the best trajectory to achieve and stabilize this high grade listhesis. That is possible with MIS because you have the freedom to choose your entry point. You are not restricted by the paraspinal muscles, the tension in the paraspinal muscles. Again, the tube helps in guiding your instruments, into the disc space throughout the surgery. So using your shavers to open up the disc space, hammering in the cage, all is done through the tube, uh, and you get a perfect reduction. So I try to impress the audience with the potential benefits of MIS in almost every horizon, every indication of spine surgery. So minimal access surgery is a game changer. It can be defined as a procedural approach that by virtue of surgical technique results in less collateral damage, decreases morbidity, and provides patients with a more rapid recovery related to the traditional procedures that again with the smallest footprint. So MIS stands on the six pillars, six T pillars that are famously called. So target. So choosing the right patient, you have to your patient selection has to be absolutely perfect. Your procedure choice has to be absolutely perfect. The technology that you use, it combines the patient is very very important, the surgery that we do is very very important, and using the right technology for that particular surgery very 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 important, and the right technique for that particular surgery using MIS is important, and to be trained in that kind of surgery, whether it is an endoscopic surgery, whether it is a tubular surgery, whether it is a destando. So it is an interplay of acquiring knowledge, acquiring skills, and executing them on that particular well selected patient with the right technique using the right technology. And then once you do these, you do your own audit. So test your own audit, that is in terms of reviewing your skills and publishing them, and that is how you get talented in these kind of surgeries and become a master. So this is how you test yourself. You do these kind of cases for years, months, and then you master them and do your audit, and then they become a source of publication. At the same time, never compromise on these four factors: stability, alignment, biology, and function. So without compromising on these, you achieve your outcomes. So the take home message would be start using these tubes, buy these scopes, go ahead. Thank you.
Thank you. It's always a pleasure. And you are someone who has started long before most of the guys jumped in. So the guys who want to start today, and they keep saying that, it's very difficult, it's expensive, you need to do training and all those sort of thing. And you started 15, 20 years back. What will you tell them? What will you tell how to go about the journey? Because most of the people, the fellows and everyone, they want to start a MIS journey, but they always have a doubt that okay, it's expensive, the equipments are expensive, the learning curve takes very long. What will your advice to these guys?
Yeah. In the initial phase, when you're not started your practice, you're absolutely insecure. You don't know whether you get patients, forget buying the tube. So I don't think is you should have a confidence in yourself. Spine is a minefield. If you start doing good work, you get enough patience. And me and you have seen so many fellows coming to us for learning. They should have adequate amount of open surgery exposure initially to know the anatomy well. They should understand the disease processes well before jumping into the tube. Of course, all can happen simultaneously, and we'll learn under mentors. I think mentorship is very, very important with when it comes to tube. If you have a good mentor, it is like see one, learn one, and teach one. It's similar to that. Of course, it takes time. So when I was with my mentor in Toronto for 3 months, I must have seen about not more than 10 decompressions, about not more than 3 to 4 tea leaves. So I think it's not very difficult. You need to have confidence in yourself. You should invest only in this initial part of your life, not in your flat car, etc. That will all happen. That will all follow. You should only invest in your instruments.
So if you invest in your instrument early, later on you can invest in a big BMW. That is the message from our physical therapy. But one more thing, what is happening is most of the guys today, they do a fellowship with someone for small and they simply dive into MIS without, having the background of what spine is. Your last slide was paramount, that the basic principle of spine surgery never changes, no matter
Yeah.
what you so what will you advise me? Do you think it's adequate enough just to go into MIS? Or do you think that, as you told, and it's become very difficult at the same time because the guys who are with me, or maybe some of the guys with you, they don't see open surgery. How will they understand the principles? Because what we are showing them is only MIS. So the problem in my unit, I'm the only one who can put an open screw. They don't need me for a MIS screw. I never go in my OR to put a MIS screw. But when there is open screw, I'm the only one who can do it. So if the world is reversing. So how will you go about it? What will you tell them? Should they go and see someone open as well after seeing you or after seeing me?
No, I have a good combination of open and MIS.
Okay.
They get an adequate exposure of both. Though the ratio is not as high as a open spine surgery unit, but they have some idea. I think, but spine surgery you can't just do 1 year fellowship and jump into practice. It took almost 4 years for fellowship for me to get that confidence and jump into practice. Understand every disease process well. Understand when to operate, when not to operate. Do the select the right patient. These are of so paramount importance that we keep chasing the technology and technique.
So Dr. Vishal Pesiti are also there. Dr. Vishal, what do you think? What is the adequate time someone should train himself? Doesn't matter like to become a MIS surgeon, because there are now 1 month, 15 days, 2 weeks fellowship, and everyone becomes MIS surgeon. What is, like, you guys are there, you've done it, and you have gone through the learning curve, and still, sometimes it becomes tricky. What is your advice to these guys who are listening to this webinar?
Not going to end. Like when I started, there was nothing like MIS surgery in 98. Then I retrained myself 10 years after my MS to learn minimal access surgery. After that, again, we retrained to learn the lateral surgery. So minimum, what you should be for our fellowship criteria when we take up a fellow is that he must have done at least a year's work in a general hospital, preferably with an open spine surgery as the primary focus. Because as you correctly said, in prior practice, we are evolving into more and more MIS. So if your foundations aren't good, it's not going to work. It's not going to happen that you get trained in a month's time in any procedure, tubular, endoscopy, or for that matter, even open surgery. To learn open surgery, it takes a couple of years. And then you can refine it into an MIS surgery for minimum 18 to 24 months. That's what a minimum spine fellowship should be. Anything smaller, like Arvind said, is not going to help. I mean, Arvind, I think, trained for more than 4 or 5 years around the world to get it off. And his primary training was in KM with Dr. Larry. So even with that, and it's a continuously evolving process. As we speak, what we are doing is probably going to be redundant 10 years down the line. So training has to be there. And for people who come for MIS fellowship, I think the open fellowship training has to be much, much more focused before that.
Yeah. So I think most of us as a panelist, and we agree that the training, and as the 60s, I know that is one of has been that Dr. Arvind talked about. I think it is paramount to follow those principles and to go about it. And with this, Dr. Arvind, just hang on if you can. Otherwise, if you have the talk, I know you are there
One
with.
more thing I
Yeah,
want to tell
yeah,
is I always tell this to my fellows who say I have got a 1 month training or a 6 week training. It's not just about learning surgery. It's about learning which patients to operate. So it's very important to attend the outpatient with your consultant to see which patients he picks up, what he counsels them. And this other important thing is to review and follow up on what has been operated previously. So you have an idea of at least the short-term follow-up of every procedure you do. Otherwise, you know how to do MIS discectomy, but you don't know what is going to happen long term. Or if you're going to do an endoscopic procedure, but you don't know what is the long term follow up, then you're not trained. Then the complications come up and you don't know what to do. So it has to be adequately long enough. And OT training is important, but outside OPD training is also equally important.
yeah. So completely agree with those words of wisdom. It's not about, just seeing the cases. Spine surgery goes beyond it. You need to understand which cases to operate. And more importantly, you need to understand which not to operate. And that is what, and even today, there are times when you make some mistakes and you go back and you learn again, okay, maybe there was something better could have been done. So I think that are the words of wisdom which you can take from the first talk, which is the introduction to MIS. That it's the 60s. Dr. Arvind Kulkarni talked about is the article from Roger Hartle. Those who want to become MIS surgery, please go through the article. There's a beautiful written article, and you should follow those principles of 60s. With this, thank you, Arvind, and please stay back if you can. But I understand you are in another meeting. So we can, if whenever possible, we will try to have you as a panelist. So let's move on. Abhijit is there. Abhijit, are you there?
Yeah, I'm there.
Yeah. So next moving on, once we have an introduction to MIS, we need to know how important it is to select the MIS surgery. If you cannot select those initial surgery wrong, you have failed even before you started. And this is what Abhijit is going to talk about. Over to you, Abhijit.
Thank you, Ayush. Thank you, Team WIROC, and thank you, Dheeraj, for this opportunity. Now we are going to discuss about how to select these cases for minimal invasive spine surgeries, mainly the lumbar spine surgeries. So when it comes to MIS and lumbar spine, we mainly think about minimal invasive tubular discectomy or the endoscopic discectomy, and the minimal invasive TLIF, which is commonly done nowadays. The OLIF, which Ayush regularly does, I do occasionally, and the minimal invasive stabilization in fractures. So I'm going to show you cases and see. So case by case, we'll discuss indications, and at the same time, we'll discuss some contraindications or some relative contraindications for this kind of procedures. So this is kind of patients which regularly we see in the OPD patients. This is a young patient with severe radiculopathy who has failed conservative management. The MRI shows there is a L5S1 exuded disc. So usually when we try to consult this patient for about 4 to 6 weeks, and if they don't respond with medicines and physiotherapy, we do offer them the surgical options for these patients. Or patients who have weakness to begin with, we offer them surgery to begin with. So what options in this patient is a straightforward L5S1 disc. So the options here can be either MIS tubular discectomy with an either 18 or 16 millimeters tube, whatever you are comfortable with. If you are good at endoscopy, you can do this interlaminar endoscopic technique as well. Sambhav is very good at this. This can also be dealt with the transfemoral approach, which if you are confident to remove that exuded fragment from the transfemoral root. And nowadays, the UP is also getting popular. So all these techniques are minimal invasive approaches to the lumbar spine, and they can easily deal with this L5S1 disc and radicular pain in these young patients. But at the same time, you should follow the technique which you're comfortable with. And this will, and you should ensure good results to your patients. So L5S1 disc which has failed conservative management is an ideal indication for tubular discectomy. Now at the same time, we'll look at the contraindication for a MI discectomy. This is another young patient who had an L3-4 calcified disc, large calcified disc at L3-4, severe radiculopathy, not able to walk long distance. Also, SLR was positive, obese patient. If you see the X-ray, there is a calcification at this level here at the L3-4, so it's a calcified disc. So it's a difficult disc to remove with a minimal invasive approach, and the chance of recurrence of radiculopathy. Now, I did offer this patient a fusion surgery for this large calcified disc for L3-4 obese patient, but he was damn adamant not to have a fusion surgery because he was just 30 years of age. So, though it's a relative contraindication, I myself did a MRI discectomy for this patient. He was relatively pain-free, but this is his MRI after a year of so his pain did decrease, but you can see there is still some amount of stenosis in the foraminal region, and he has some pain. Once he comes for follow-up, every yearly comes and shows me that there's some pain. So I knew that this could have been a fusion case, but since the patient was very rigid about the MIS discectomy, so I use a tube, about 20 millimeters tube, to remove this calcified disc. He is doing much better than what he was before, but still not happy. So I would suggest a large calcified disc, central disc causing severe cardiac compression is a relative contraindication, and it's either to go for a fusion or in these cases. So this is another indication for the MIS TIL. Now we are going to discuss about MIS TIL. This is a recurrent stenosis in a 74-year-old female patient. L4-5 decompression was done 2 years back. Now, recurrence of symptoms, you see the X-ray has instability and there is stenosis and listhesis. So this is a classical indication for a minimal invasive TLIF. Since the patient is obese and elderly, you can avoid the central scarred area and do this minimal invasive fusion with safely and accurately. There's some people who will do the OLIF in this approach as well. I don't prefer OLIF because I'm a little worried about the bone grafts which are available for OLIF. So I would prefer a minimal invasive TLIF with a tube. I'm sure Ayush might offer OLIF for this patient because he's more comfortable doing that, and maybe he has access to BMP or more higher bone grafts like Grafton from Medtronics. So I would prefer a minimal invasive TLIF. So this is what I did for this patient, MIS TLIF L45. So classical indication for a minimal invasive approach. Again, a lytic spondylolisthesis in a young patient. You can see there's a pars lysis at the L5S1 level, and listhesis. Patient has failed conservative management, severe symptoms, and can be effectively dealt with a minimal invasive TLIF at the L5S1 level with the use of tubes. So another indication for minimal invasive TLIF. Multi-level instability patients, multi-level stenosis in elderly patients can also be dealt with a minimal invasive approach safely and effectively. And it's a good technique for obese patients because it avoids infection, avoids resection of the midline structures, and the risk of infection is almost zero, and the patients are mobile early. Now, another relative contraindication for minimal invasive fusion surgeries is osteoporosis. And this is one of my patients who was obese, 65-year-old, relatively, though she was osteoporotic, I did offer her minimal invasive fusion surgery. And this was her, on the left side, you can see there's this X-ray showing back out of screw. So if the BMD is less than minus 2.5, or the patient is really old, or then you should consider that can you really put the implant properly, and you should be worried about pull out of the implant, because in MIS surgeries the rod tends to go to the screws. So if there is high grade listhesis, screw might back out. So this is what has happened in my patient. Maybe the screw was loose to begin with, but at the 2 months follow-up, she had this back out of the cage and screw back out. So I had to go down and revise this at the end of about 4 to 5 months, and then also treat her osteoporosis. So severe osteoporosis with BMD less than minus 2.5 is a relative contraindication. However, you can use cement augmented screws, or you can correct osteoporosis to begin with and treat this patient with the minimal invasive approach. So it's not an absolute contraindication. So it's good to know the BMD in this female patients, elderly female patients with multi-level instability or who need minimal invasive spine fusion surgeries. Again, degenerative scoliosis is can be effectively treated with the minimal invasive fusion surgeries. This has a patient with stenosis and listhesis. He has pars L5S1 lysis at L5S1 and degenerative scoliosis. So this can be dealt with an OLIF approach effectively, but people who are trained well in OLIF have access to the instruments well, have access to the bone graft, should do this OLIF. It's definitely a better technique than a multi-level MIS tele for this kind of patients. In these patients, since the symptomatic level of the L4-5 and the lysis at L5S1, I did only the L4-5 and L5S1 fusion surgery in this patient with the minimal invasive T-leaf approach. He did well. This patient did well eventually, because that was the most symptomatic level of the lysis at L5S1 level on the CT scan. So similar patients can be dealt with the OLIF approach, where there's deformity and stenosis in the lumbar spine. I am I'm not a big fan of OLIF. One of the reasons why I feel is that I don't have good access to bone BMP because it's expensive. I don't believe in the cadaveric graft for lumbar fusion surgeries and the G bone. But I think if you have graft on and good bone graft, OLIF is an excellent technique to achieve indirect reduction, achieve the deformity correction in these patients, and then you fuse them with a percutaneous approach. Of course, Ayush has extensive experience in OLIF, so he can tell you better. My experience is not much in OLIF, but still OLIF is an excellent technique particularly for degenerative scoliosis and multiple level lumbar problems, where T-leaf can become a little difficult. It can be technically challenging. With OLIF, you go from the concave side, you can address 3 or 4 levels easily with the same small incision from the front. I prefer to have an access surgeon who is standby. I mean, I do my access myself, but I tend to have somebody like a vascular surgeon standby in the. I inform him that if there is some episode, we'll call him, so he knows that we are doing this case. Though he's not in the operation room, so they are aware that we are doing this case. In case there is some bleeding episode, they can help you right away. Another cases where the minimal invasive OLIF can work is the adjacent segment. It's an excellent technique for adjacent segment stenosis. This patient who had an L3-4, L4-5 fusion, postlateral fusion, came to us with adjacent segment stenosis and claudication. And he was not willing for the big screws and all those things. So we offered him this OLIF approach, and we did the OLIF at the level of L3-4. And we went from the front and we used the grafton graft along with some bone marrow aspirate from the iliac crest. However, we did not extend the fusion at the above level. We just did the anterior approach, and this patient eventually fused well. So OLIF is an excellent technique for adjacent segment stenosis. It's an excellent technique for degenerative scoliosis. So degenerative scoliosis and adjacent segment, you can deal effectively with OLIF. However, Ayush is the best person to tell you about OLIF. Now, there are some contraindications. This is another patient who came to us with following an open T-leaf. She had an insufficiency fracture at L5. Elderly patient, 74-year-old female. Now, this patient she was a non-walker, neurodeficit, I mean, because of severe pain. So this is a contraindication for minimal invasive procedure because it's extremely challenging. There is a fracture, there is a non-union, and there is a cage has migrated into the vertebral body. So you got to take care of a lot of things. It's good to do with an open approach, extend the fusion from L3 to pelvis. So that's what we did here. We did L3 to S2 posterior spinal stabilization fusion, removal of hardware. We could not remove the cage because it would lead to further bone loss. We did the interbody fusion with local and the cadaveric bone graft at the L3-4 and the L5S1 levels, and this patient from non-walker, she became a walker. Of course, we did use anti-osteoporotic agents later on for to enhance the bone marrow density, like teriparatide and denosumab. Another related contraindication for minimal invasive procedures is infections or or kind of these are tumors. This is a tumor in the sacrum in a 14-year-old female patient who had weakness in both lower extremities, non-walker, severe pain. So this is relatively difficult to remove with a minimal invasive approach. So we did embolize this tumor, and then the second stage we did the excision of the tumor, and we filled the cavity with HA bone hydroxyapatite bone cement as well as bone graft, cadaveric as well as local bone graft from the iliac crest. So this patient is doing well. So this is a large infection is a relative contraindication for this kind of procedures. It's good to avoid minimal invasive procedures in this kind of patients. So this is another patient, burst fracture with intact neurology, elderly male patient. You saw the X-ray was almost normal, but he had severe pain, non-walker patient. And we did the CT scan and the MRI, and you see this incomplete burst fracture. So we had to, he had undergone minimal invasive stabilization. This is the right indication for this patient. You can go 2 levels above, 2 levels below, and stabilize the segment and achieve reduction. And these patients do tolerate the surgery very well. Similarly, if the patient has a relative contraindication as a burst fracture with a large electropolis fragment, if it is causing severe coda-equine compression, this patient presented with D12 burst fracture and paraplegia. So this is a relative contraindication because here the priority is decompression, removing the electropolis fragment, and realigning the spine. So relative contraindication for minimal invasive procedures, but there are some people, I'm sure, in this faculty or others here would do a minimal invasive for this fractures as well. But I would prefer to do an open surgery. So we did an open, this was an MRI and the CT scan of the patient, and we did open decompression. We removed the electropolis fragment and stabilized this patient. Now this patient is gradually on the path to recovery. So minimal invasive surgery has definitely big roles in lumbar spine surgeries. There are some contraindications where you should avoid minimal invasive surgeries, where there's tumors, infections, large deformities, and fractures with large significant compressions. Thank you so much.
Thank you, Abhijit. Quite a elaborate series of cases. So, what will you tell to people who are planning to start MIS? Which cases should they select when they want to venture into MIS?
Say it again.
Yeah,
So initially, I would suggest they should start with a slip disc or a simple stenosis, single level stenosis.
Okay.
Yes, you might take a little more time to begin with, but I think a single level stenosis, a single level disc herniation is an easy level. You can spend a little more time in the OR, but you can achieve expertise about learning curve about 15-20 cases once you're done your fellowship. So I would definitely recommend minimal invasive approach, whatever you're comfortable with. I used to do a lot of endoscopic transfemoral discectomy, Ayush, and then I saw a lot of recurrences myself. And I actually backed out from that technique because in a setup where I am operating, I was a little worried that seeing the recurrences. So depends on where you're practicing. So this kind of setup where everything has been closely watched, your results are closely being watched, you have to be very careful in what approach you use for those patients. In a medical college setup, it's relatively forgiving, I feel. You can do some level of errors would, I think, go unnoticed. So I myself was doing a lot of transfemoral endoscopic, but then I gave up. Now, hopefully, and I'm going to switch to interlaminar. I have once we have the right instruments, I'm planning to start interlaminar decompressions for disc herniations.
So, Dr. Vishal, what will you suggest which are the cases you will recommend the new guys to start with?
If you are a right-handed surgeon, you should do a left-sided L4-5 disc herniation as your first case because it's easy to access. It's from your natural side. You use your right hand to reach there. L4-5 is usually perpendicular to the floor, so you don't have to move your microscope to an angle to reach L5, S1, L3. Once you're confident enough of doing your discectomies, then you should proceed to decompressions. First, unilateral. Again, if you're a right-handed surgeon, on the left side first, L4-5 ideally. And then as you do more and more, you can go over the top, learn over the top techniques. When you are able to do your decompressions well, is the time to move on to a TLIF. And TLIF also, the first TLIF I did was an L4-5 level TLIF on the left side. Ideally, don't choose a very fat person or don't choose a very thin person, because the tubes tend to pop out if the person is very thin. So it should be a reasonably fit 4-5 level that you should start with. These are cases which are more easy to do. And once you're sorted, you've done a couple of dozen, you know what is happening. My other advice is to collaborate. When I started doing my TLIFs, I collaborated with my senior and colleague, Dr. Devesh Dolakia. We walked each other through our learning phase of MIS TLIF over the past 2 decades that we've been doing this. And that helped, having a second opinion. And of course, you cannot do your cases without proper equipment. If you don't have proper equipment, it's better to do a good open surgery than to do a blotched up MIS surgery.
Thank you, Abhijit. And moving ahead, we have ICOB. ICOB is the head of neurosurgery and spine at West Georgia Medical Center, and he does a lot of MIS work as well. We had a chance to collaborate and to interact, and that is how. And he is a gem of a guy and an excellent neurosurgeon. So ICOB will be talking about the tubular approach in disc. So ICOB, over to you. Hope and we hope to see you soon in Mumbai as well.
Yeah. Hello, everyone. Thank you for such kind of introduction. Actually, for me, it's a great honor to give a talk with such kind of titans. It's for me big pleasure, and thank you again. I would like to make presentation about MIS surgery, how I started this type of surgery, and maybe young generation maybe for young generation can be it's more very useful because I am a traditional neurosurgeon. Mostly my daily work, like 50% of my cases is spine nowadays. And I'm doing mostly vascular, cranial cases, but still nowadays 50% of my cases is spine. My first journey into the world of the MIS spine was in May 2022. It was in Mumbai when I had the opportunity to be part was a part of hands-on cadaveric workshops in Mumbai. Before it, I had experience as an open surgeon. Maybe I had more than 1,000 open case. When I have backed my institution in actually it was after 1 month with my colleagues, we have started MIS trauma case. Nowadays, since 2022 until today, we have done 50 MIS surgery for trauma case, and it's like 200 for lumbar microdiscectomy and lumbar spine stenosis. Also, we have an infection case, and I think it's a very good option for spondylodiscitis. Almost 30 cases of MIS TLIF, and I would like to tell you, for me, to be honest, tubular posterior cervical foraminotomy is the best mini-invasive treatment for spine, because you can avoid muscle damage, you can avoid severe pain after the operation, and of course we have some tumor cases when you need to stabilize, and of course also we can do with tubular decompression of spine. From 1996, there was plenty of publication.
Your screen, we can only see the first slide. Is not
really?
Yeah. Just make it full screen, and your slides we can see. Well, yeah, now we can see. Yeah, okay, thank you. Yeah, now we have your slide. Yeah, you go ahead now. Yeah.
Is it okay?
No, full screen, please.
Full screen.
Yeah.
Okay.
So here, down here, you go and do the full screen. Yeah. Now you move your slide, please, because earlier we were on the only one slide. No, you have to go full screen here from the down Yeah, somewhere down. Yeah.
Is it okay now?
It's not, we have a black screen right now with in front of us. So yeah,
Is it okay?
it's not full screen actually. It is showing in the presentation mode. The
It's fine. What you can do is you can just forward it in this mode if we are not getting the full screen. So we are at least getting to see some part of the slide.
yeah, so you can move ahead. You have to move each and every slide then individually because yeah, I can see your first slide now. Yeah. And then you have to click on the side slide. Yeah, that way. So whichever slide, yeah, you can click that button, the earlier button.
Okay.
Yeah. You have to do this way. Yeah. Go ahead, please. Yeah, we can
Okay.
see now. Please go ahead. Yeah.
What's the problem? Okay. Okay, as I told you, it was my first experience in Mumbai in 2022 when we have done this live cadaveric workshop, and it was my first experience when we have started when I saw MIS and tubulars. And after just 1 month, it was enough to start MIS trauma cases in my institution. But of course, before it, I had experience of open surgery. But I think it's not big deal to start MIS surgery if you have, of course, experience to do open cases. It's in my cases. You can see trauma was like 50. Nowadays, still since 2022 until today, we have done more than 200 cases of lumbar discectomy and lumbar spine stenosis. It was a 20 infection. For infection, also 30 sleeve surgery, and 10 like posterior cervical sequestectomy and foraminotomy. I think, as I told you already, posterior cervical foraminotomy is the best when you are doing for tubular because you can avoid muscle damage, and after the operation, patient has a less pain. Even from 1996, there was a plenty publication about retractor blood pressure and duration relates to levels of CPK, and it's one cause of to be a reason of infection. Even sometimes superficial infection is sometimes a big problem. That's why it's after my tubular experience, I'm not such experienced as you guys, but I had maybe like more than 300 cases, and infection rate is like 0. And it's a dramatically, it's like game changing in terms of infection. And if you consider back pain, you see short after the operation, you have less pain, but in the long term, in terms of back pain, maybe its result is the same. In terms of radiculopathy, maybe it's the same if you compare open and mini invasive, at least in our cases. Of course, blood loss. Blood loss is one main benefits of MIS sleeve. If you see here, it's maybe 3 times less in terms of blood loss in our series. Okay. What's about position? Position is the same as open surgery. We are using a Wilson table, and you need this type of instrumentation. I think it's longer ones, like long caissons and long hooks, and of course you need as usually high-speed reel. I would like to show you one case how I'm doing bilateral disc hernia. As always, indication of surgery is a failed aggressive medical treatment like non-steroidal and steroidal, also physical therapy. I like also to use epidural steroid injection. As you know, there is no good evidence about steroid injection, but I think it's still working. There is a different surgical approach nowadays. Several approaches have been adapted and described over the 20 years. It's like a conventional midline approaches often utilize large laminectomy and partial facetectomy to expose herniated disc for surgical removal. However, this approach may lead to intersegmental destabilization of lumbar spine. And in 1953, Watkins described a paramedian approach that was later modified by Wilse to split paraspinal muscle and preserve facet joint to access foraminal and extraforaminal segments. But in last more recent advent of MIS surgery is after the introducing of tube, I think, because spine surgeon enabled to approach extraforaminal region with minimal disruption of the stabilizing tissue of lumbar spine. There's a several modification of MIS techniques. You can see one option is to dock tube in this area. It's it's a transverse process of the superior articular facet of inferior vertebra, and then to palpate inferior pedicle. Like second approach, it's a cranial to caudal, also known as a top-down approach. In fact, the tube should be docked on the pars interarticularis, and the ligamentum flavum. The ligamentum flavum is a cranial aspect from your tube. And with a ball tip probe, it's used to palpate the upper pedicle from the below. This allowing to locate root. Once the root is exposed, the disc located caudally could be approached safely. Okay, I would like to show you my case. Actually, it's a good publication about anatomy of bilateral disc space. Is it working, my video now?
We can see the video. Go ahead. You can see the video.
Okay. It's a young patient with a bilateral disc hernia. You would like to use a X-ray to identify exactly level. And after identification of exactly level, 2 centimeter paramedian incision is made. And the wound will be dilated with up to about 60 millimeter dilatator, and then put over the dilatator 80 millimeter final tube. After the final tube is placed, what we are doing, we're making again X-ray, and X-ray will demonstrate our tube proper position, as you see here. After that, starting to use a microscope, and monopolar is used to identify normal anatomy, including the medial aspect of transverse process, lateral aspect of the pars interarticularis, inferior articular face, and superior articular facet and facet joint line. The lateral facet of the foramen is palpated and enlarged using a high-speed burr, and as you see here, ongoing hemostasis is secured with a bone wax, or even monopolar can be used. After the Carison, we can remove some part of bone, and we can identify perineural fat. The exiting nerve root is then exposed by using Carison upcut to remove part of ligamentum flavum and facet joint capsula. Using microbe, as you see here, now maybe, okay, you can see perineural fat. And in my left hand, I have aspirators with a nerve root retractor, and starting to find sequestration with my right hand to identify some fragments. Even these small fragments can cause severe pain due to location of dorsal root ganglia. And as you see, we found this fragmentation. Second nice case for tubular, I think it's a L5S1 level, L5 disc hernia. And if you compare like a open interlaminar approach, you can preserve more bone with this approach. And nowadays, I don't like to remove. I don't need at least to remove bone because always I have enough space, enough window to approach L5 disc. As you see here, just small removing, some small unroofing of S1 root is enough to see axilla, and between axilla and dura mater you can very easily find this big sequestration without removing of facet. Even medial there is no necessary to remove some part of medial facet joint. Okay. And nowadays I can say I'm not experienced like you, but mostly we are using 40 millimeter diameter tube, and it's completely enough for me. Okay, it takes some times, but I think learning curve is not so long like endoscopic maybe. I think if young generation have experience to do open surgery, after they can find some good workshops, cadaveric workshops. It's completely enough to start in your institution this type of surgery. And I am one example how I have started this type of surgery after just 2 workshops in Mumbai. Thank you, everyone.
Thank you, and it's good to see the progress you have made. One of the reasons of bringing you here is to make it, to let people know how to go about the journey. And it's very impressive, and we are so happy that you have achieved what you have achieved. But going back, was it difficult for you to, change your approach from open to tubular surgery? And just for the youngsters, what are the few tips and tricks you will give to them? How to convert a spine surgeon from being an open surgeon to a MIS surgeon the way you have done it?
Actually, to be honest, I had before tubular and before MIS surgery, I had more than 1,000 spine open case. And personally, I have started with easy case, like as my colleagues Arvind says already, it was like L4, L5 tubes, and it was like 20 millimeters. Even in this time, I did not use the 22 because I have nowadays Metrix tubular, and it was like 20. And after like 5 or 6 cases, started to use 18, 16. After like 50 lumbar discectomy was enough to start MIS sleeve surgery. After MIS sleeve surgery with my colleagues, and Giga is here, we thought maybe it was enough. It was a time to start MIS infection, and it's really. I think it's a really game changing when patient is a somatic and patient has many comorbidities. And you can do this type of surgery just 2 hour, even longer instrumentation and decompression, and patient is doing well after the 24 hour. It's really amazing. And of course, infection rate, really, maybe I don't have many cases, but already it's a 300 infection. We had 0, really 0, even superficial infection. Maybe per year, I am doing 500 case, like 50 of them are spine. And before MIS, before tubular, my infection rate was per year like 2 spondylodiscitis, maybe 5 or 6 seroma or some superficial infection, and nowadays it's 0. And after like 100 lumbar, I have started to use it for cervical, and cervical is I think it's a better than.
I think they are the most happiest patient when once you do those cases.
Cervical, I think personally.
Yeah. So, Dr. Vishal, your take on the progress ICOV has made and his journey is how it has been all about.
Yeah. He's the person who is ideally suited for MIS. I think neurosurgeons, for them,
He's
it's
a
a
neurosurgeon. He's a
natural
neurosurgeon.
upgrade. For them, it's a natural upgrade to start because they are so used to using a microscope. So it is just a question of limiting your field. I trained with a neurosurgeon, Dr. Umesh Vensarkar, who was the head at Nair and at Harkisanda. So it was easier for me to go to tubular. But for orthopedic surgeons, because they do a lot more scopies, it is easier to move to scopy. So so now I mean, because in our training, scopy was something that we didn't do very much. It was much more difficult to get used to a scope than it was to get used to a tubular surgery, because microscope was something that like for neurosurgeons a natural progression. It's great to see him change. I think this was a JJ Hospital workshop in 22 that he had come to.
Yeah.
Before, actually, I was also 2017 in Mumbai with Professor Sandeep Sonone. It was like cervical spine workshop. And really, I am a good example, maybe. I'm not saying that I am very experienced, but it's really happened if this type of workshops, like it was like 1 week workshop, was completely enough. But of course, you need to have a basic knowledge of anatomy. Of course, without anatomy, without open surgery, it's impossible. But it's completely easy. I had also opportunity to stay with Dr. Ayush. Maybe it was a 3 week in his department, and I just have observed cases, and it was enough. And when I have sometimes presentation in my home country, sometimes my colleagues asking me, is it tubular is enough to do decompression? But personally, I'm thinking, I'm doing MRI sometimes because to show them you can achieve even contralateral decompression very easily, just undercutting techniques, just to turn a table. It's completely enough. And I love tube. And thank you, Dr. Ayush.
No, thanks to everyone, Vishal, Pesetivar, and these guys have really sort of allowed people like you. But the most important thing, you were a good experienced surgeon with a good brain inside your head, and that is most important. More than that, and that is I believe those who have good experience, those who understand anatomy, for them the transition is much more easy than those who just are starting to start the spine journey.
Yeah.
So I think we'll hear much from you and your experience when you visit us again in Mumbai. Thank you for taking your time out. And just to move ahead, we now have
one more thing.
Actually,
Please,
please,
a very important takeaway message here that a lot of seniors are very reluctant to get into, to retrain them, to retool them. Actually, they have all the skills. It's just a matter of changing your point of view. And being a little more flexible with your attitude towards surgery. That's all it takes. Dr. Aikab is actually an ideal thing. He's a senior guy, well trained. It just took him that shift. Okay, I want to do this new. We are so many who are reluctant. The message to them would be, please don't be rigid in that what I have learned is what is going to be the final thing. It is surgery is an ever-changing branch, and unless you tend to change with the tide that has come in, you will sink or you will be left high and dry.
Thank you, Vishal, for those words of wisdom. And moving ahead, let's move from tubes to endoscopy. And we cannot have anyone better than Sambhav. Sambhav, you are there? I hope you are there.
Yeah. Thanks.
So Sambhav, we're talking about endoscopy. Is it the real future of spine surgery? The world is sort of, shifting from tubes to endoscopy. So let's see how good, bad, or evil is full endoscopic surgery. Over to you, Sambhav.
Thanks, Ash. Can you see my screen?
Yeah, we can see. We can see you.
So now from after we spoke about tubes, we are going to move on onto a uniportal. That is a full endoscopic approach. So obviously, as you see here, open surgery versus tube surgery versus an endoscopic vision. Now, this slide is not just to compare the visualization or the magnification of the surgery, but one very important thing is that you cannot venture into endoscopy unless and until you have not travel through the path of open surgery, tube surgery, and then going into endoscopic surgery. So even till date, in spite of doing many cases, I still keep my tubes on standby. Unfortunately, it's not that I have 10 scopes lying around or a lot of extra instruments. So in case something goes off, at least my tubes are there on standby for me. So learning, going through this journey is very, very important because the bigger approach, you'll see a lot more anatomy, and the smaller you go, the anatomy keeps on reducing. So identification of the anatomy is the most important, and then execution becomes much, much easier. So your approach for endoscopy has to be through this. Observe a lot of videos, do a lot of cadaveric workshops. Ayush, Dheeraj, all of them. They every year we have a lot of endoscopic workshops in Mumbai as well. So invite everyone to come over and join these workshops. So one of the biggest advantage of endoscopy is the visualization, the magnification. We use a continuous saline irrigation, which creates, a very good planes for us to do our discectomy. So eventually, the target is the same. If you want to do a discectomy, you want to do a decompression, whatever means you do, either open tube or endoscopy, our end target is the same. It is just a different approach of trying to achieve that target. So I feel one of the biggest advantages is visualization, magnification, even bleeding, because you're using pressure irrigation. The amount of bleeding which you see is much less, especially for posterior cervical endoscopic foraminectomies, where you encounter a lot of epidural bleeding. So the continuous saline irrigation definitely helps us in bleeding. With the endoscope, especially the interlaminar, you can zoom in, zoom out, you can go up, down. So it's a very flexible approach where you can easily go into whichever direction you plan to, where your pathology is. So even doing over the top, or if you want to even do a ipsilateral foraminal decompression, even all that is very easily achievable through an interlaminar approach because of the flexibility of the scope. So as you see here, you can go right from pedicle to pedicle and achieve a good decompression. So, when people say that minimally invasive surgery cannot achieve the kind of decompression, pedicle to pedicle decompression, definitely it can, even using an endoscope, because eventually you are doing the laminotomy, you are doing a flavectomy, you are removing all the structures which are compressing your chorda equina, and this can be easily be achievable through an endoscope as well. One of the biggest advantages of an endoscope, especially a uniportal endoscope, is that not just the interlaminar approach, but you can actually go directly into the foramen. So when you have a foraminal disc, foraminal stenosis, or extraforaminal pathologies, you are directly targeting that pathology, and there are no other structures, no bony structures which come in your way. So this, I think, is a beautiful approach to use. Although our work as endoscopic surgery is almost 70 to 80% interlaminar, but still there are those cases where a transforaminal approach is a complete boon, and everyone should be knowing how to access this approach. Because the incisions are so small, the muscle dissection is so small, even in patients who are very obese, where you have to do, take bigger cuts, they're very deep. You can even sometimes, even tube surgeries, although tubes also for obese patients are a complete boon. However, I feel that endoscopic surgeries are executed much more in an easier fashion, where your visualization is beautiful, even in these obese patients. Another thing is we can do this under local anesthesia, where the patient itself is your neuromonitoring. You can ask them to move their legs on table, especially when you're doing a transforaminal approach, when you're close to the exiting nerve. Doing it under local anesthesia becomes very easy. Even the interlaminar approach, you can do it under sedation, under spinal anesthesia. So it becomes like daycare procedures where patients can be discharged back home, 3 to 4 hours after the surgery. Obviously, if you are doing endoscopic surgery, and this is, I think, with regards to any surgery, there is a lot of discussion sometimes that the cost of endoscopic surgery is very high, especially uniportal. However, even if you're doing tubes, you require a microscope. Your hospital has a microscope. You don't find surgeons roaming around with microscopes. However, I see an advantage where me personally in my private practice, I have bought all these instruments. It's a one-time investment, and I take it to all the hospitals I venture into. I'm not bound to one hospital, so I feel in fact this is a bigger advantage over a microscope. Microscopes are as expensive, so the whole debate about it being expensive, I don't think holds true, because for any kind of surgery we do, if you're doing navigation, you're doing robotics, you're doing microscopic surgeries, in the initial investments are required. So for endoscopy, there are a few instruments which are very typical for endoscopy, especially the radio frequency unit. The burrs, you cannot use regular burrs, they are longer burrs. The instruments, although the kind of instrument we use are similar to open surgery, but the lengths are longer. You need longer instruments. So you have to invest in the whole instrument set in order to start your journey in endoscopic spine surgery. Now, one of the biggest advantage I feel is, so I call endoscopic surgery for the disc, especially it's a surgical strike of the disc. So any surgery which targets only the pathology without causing or minimal damage to the surrounding structures, and we leave no proof behind. So that I feel is the definition of what can be the least invasive surgery in our hands. And I think endoscopic surgery plays a very big role in this. We see post-operative MRIs where in MRIs you can see adhesions, laminectomy defects, etc. However, when you see MRI, interlaminar or a transforaminal surgery, even after 3-4 days, this was a patient whom had done an MRI after 4 days, and even the radiologist could not pick up that this patient underwent an endoscopic surgery just 4 days ago. So I feel that this is the true surgical strike, especially when it comes to discectomies. So it's a day care procedure. Results are equivalent now. We have enough research supporting endoscopic spine surgery because of the magnification. The chances of dural tear are quite minimal, especially in stenosis surgeries. Also, you see the thinnest layers of phlegm attaching to the dura. You can realize that there is stuck, and you can do a much better decompression with it. So majority of cases, what you can do in the open or tubular can be done using the endoscopic approaches as well. However, everything has its learning curve. The learning curve is quite high. It's a difficult surgery to master. So start with simple discectomies, then go on to migrated discs, lumbar stenosis, cervical discectomies. Then you can go for multi-level, and then obviously into fusions and even tumors like some tumors which you want to do, as Dr. Arvind Kulkarni showed us a beautiful case with tubes. You can actually do the same thing with an endoscopic surgery as well. So another thing is deciding the approach, whether you do interlaminar, whether you go transforaminal. So it all depends on where your pathology is. If it's a foraminal or extraforaminal pathology, you try and go into the transforaminal approach, because if your main indication or your deciding approach is, I want to use an approach through which my surrounding structures are least damaged. So including migrated, so you have to, before you start the surgery, you should be knowing, you should make a plan that whether an interlaminar approach will be better for the patient or a transforaminal approach will be better for a patient. Read the X-ray, see where the iliac crests are, see exactly where your pedicles are. So see how big the interlaminar window is. Now, in lower L5S1, the interlaminar window is much bigger, and the foraminals are much bigger at the higher levels. So accordingly, you can plan your approach. Usually my practice is 70% interlaminar for paracentral discs. However, huge central or foraminal or extraforaminal disc, I prefer using the transforaminal approach. So if you see this is a L5S1 case, now I can see on the MRI that this fragment is right under the interlaminar region, just underneath the flavum. And I need to make sure that I get these fragments, the sequestrative piece also lying around. So doing a complete job is very important. So once you identify the nerve, you can use your cannula, you can retract the whole nerve, and you can extract the piece of disc. And once you derotate your cannula again, you can visualize the shoulder of the nerve, you can visualize the axilla, you can visualize the central chorda equina. So this gives me, I know that the nerve is completely free, and I'm not worried about that this where I've left any fragment. Now, when you do a transforaminal approach, you are doing kind of an indirect decompression where you are not seeing the nerve in complete totality, but the exiting nerve in foraminal and extraforaminal cases you can see beautifully. That's why I prefer that approach, a transforaminal approach for foraminal discs. Now, if you see the post-operative MRI also, even the sequestrated, that extruded fragment has been removed. But the most important thing is, if you see, even the ligamentum flavum is completely intact, only a very small rent we've made in the ligamentum flavum. Both the muscles on either side look the same. So this is the least damage done. Now, as you venture into endoscopic surgery, you can further go into migrated disc. Now, this is a huge superiorly migrated disc. Now, there are ways to tackle this. There are some people who go make a laminotomy and go from there. But typically in these cases, you have to remove the lamina. However, because of the flexibility of the endoscope, the lamina is sloping. So you can actually go in down and then you can angle the endoscope and try to get this disc out. So this is what I've exactly done. I've docked into the interlaminar space without doing any laminatomy, any medial facetectomy. We've gone and removed that piece of disc. So this you see we are right now just that's the traversing nerve. I've seen a disc fragment over there, which is on the disc space. This is from where the disc fragment came out and it went superiorly. That's a superiorly migrated disc fragment. Once that piece is removed, my aim is to see even the exiting L5 nerve over here. So once the fragments are removed, I want to see the exiting L5 nerve. And after, once we remove that piece, we can actually see. So here, exactly the way you see the fat, that is my exiting nerve. And we can clearly see that the whole fragment has been removed. And I make sure again that I have not left behind any fragments in the disc space. So that's the disc space. So we've gone right from the exiting L5 nerve to the traversing S1 nerve. And that's the post-op MRI of the same patient where you see the fragment has been removed beautifully. Now, another patient, this patient came with a cauda equina symptoms. He had urinary retention. So can we do cauda equina? Typically, we always believe that you have to do a complete laminectomy for these patients. But once you venture and once you start your journey in endoscopy, even these kind of cases can be easily removed. You see how the nerve has completely been pushed away laterally, and these fragments are in the axilla as well. Very important is to find those fragments. Don't be in a hurry. Don't get excited once you get one fragment because there can be a lot of fragments. If you see in this case, one fragment, this is the second fragment, this is now the third fragment. So until and unless you don't see the nerve, which is completely free. Now, this is the advantage of endoscopy again. You can use the RF and I see one more fragment. Now, this fragment would probably have been missed if I was doing even probably with a microscope. So the visualization is so good, the magnification is so good that, and now when I see the whole nerve in totality, the axilla, the shoulder, I know that I have done a good job. This is again the post-op MRI of the same patient where you can see the cauda equina has been quite well decompressed. Now, at the same time, this is an extraforaminal disc. This was a sacralized spine, but however, when I saw the X-ray, I realized that the iliac crest is low. So then for me, if I have to go with the interlaminar approach, I have to remove some amount of bone. You can take a Wilsey approach, but you have to remove part of the probably the pars or the TP or part of the facet. But here, because of the extraforaminal approach, I can easily target the disc. I'm right in front. So as you see here, I can see the S1 pedicle, the superior facet, the disc space is right there, the alpha exit. And the minute you dock here, you see the fragment is right there underneath the exiting nerve. So the surgery becomes extremely easy. It's a 15-minute case and you can do a fantastic job. Now, L34 case with a huge central disc. This patient developed a left-sided fit drop, had mild retention as well. Now, if I have to use an interlaminar approach, I have to do a wide laminectomy. You might even, you cannot see the cauda equina. That's a whole disc which is lying in the axial cut. You might even consider a fusion. Now, this was a 33-year-old architect. Now, if I can manage this transforaminally, I know that the disc piece is going to be right in front of me. And you have to make sure that you are flat enough into the canal and the disc piece is right in front. Plus, the disc piece itself pushes the dura posteriorly. So you can see that the whole fragment has been removed and you can see the dura beautifully. So this patient was walking with a foot drop. He had a high stepping gait. And within 1 month, you can see that luckily his power has recovered. So even these kind of cases can be achieved. And now, once you've done a couple of lumbar cases, done stenosis cases, you've done decompression because you need to know how to use burrs. You can then start going into posterior cervical cases where you can do brilliant foraminectomies or even discectomies for lateral discs. However, once you've done I would at least recommend doing minimum 50 lumbar discectomies before venturing any kind of stenosis cases. This also was a revision case and a stenosis case. So again, stenosis, you need to know how to use burrs because there is a lot of burring required in stenosis because you have to remove the part of the lateral recess. You have to do a bit of laminectomy. However, when I've compared my cases as well, using tubes and using endoscopy, I've realized that the amount of bony work which I have to do, even for stenosis, is much less. you have to invest in a good quality burr. So we have round cutting burrs, diamond burrs, you have oval cutting burrs, you have front hooded, lateral hood protection burrs. So even a stenosis case or a case like this, which is facetal cyst, these all can be beautifully done using endoscopic techniques. You can even do over-the-top decompression. That's the base of the spinous process. And then you can completely go over the top. You can see this whole central dura, the opposite side, and complete over-the-top decompression can also be achieved. Obviously, the incision sizes do matter. This was a revision case, so the patient had done a microdiscectomy earlier. And as you see, even if you're doing a revision case, your incision size is still your technique doesn't change. So how you would do a revision case with a tube, docking at the medial part of the facet, you're doing the same things. However, I feel even in this case, although it was revision, I did not have to remove any bone, and I could manage to just dissect the plane and go in. Once you finish that, you can go into fusion surgeries, infections, tumors, anterior cervical. The future now, Ayush is doing navigated endoscopy. You can start having, virtual glasses. So there is no end to the future. As Dr. Peshativar also said, that no matter how senior or junior we are, we have to start, you have to keep on learning. You have to keep on advancing your techniques and do what the best is in your hand, at the same time, the patient's hand as well. So thank you very much. Thank you, Ayush.
Thank you, Sambhav. It's always a pleasure. So Sambhav, all the people who, were taught all the tubular till now, do you think they should simply forget everything and jump to your endoscopy?
Absolutely not. So I still feel tube is a fantastic surgeon. And as I said, I still keep my tubes on standby every time. In fact, my first endoscopy case where I'd invested so much money, I had one RF wand, and by mistake, the sister dropped it down. So I could not continue. I didn't have a spare RF lying around at that particular point of time. So I had to open it and use my tube. So even initially, I would always recommend that don't sell endoscopy. I never tell my patients that I'm going to do a small endoscopic procedure. I tell them I'm doing a discectomy. We are selling discectomy. We are selling decompression. So I don't have that pressure that I have to do it with a small hole, etc. I'm doing it peacefully. Anytime I feel I'm struggling, especially in the earlier days, I simply convert it to my tube. So tube still remains there. And to venture into endoscopy, or to make endoscopy easier, I would say first learn tubes, only then go into endoscopy.
What will you tell to those guys? We told them first understand the anatomy, understand open surgery. Then we all spoke about, oh, go and learn the tubes. Now you are coming and telling these guys, okay, now you go and learn the
Yeah,
endoscopy.
but I think that is in any case. You are a baby, you have to first sit, stand, walk, run, right? You cannot just directly go. And if you try and venture and see, you can, but then your learning curve is going to be much higher, right? Your complication rates will be higher. You will struggle and you will start giving it up. That's what we've realized. Even in workshops when we train people, that they'll end up giving up these cases because they have not gone there yet. Once you see tubes, once you know, just looking at the lamina and the interlaminar space, when you're doing open surgery, you are seeing facets and everything. So keep on watching videos, observe. Even when someone's coming over to observe me or my fellows, I tell them there are lots of videos available on YouTube. Just observe, where you don't have to ask me what is right, left, medial, lateral. The day you know that, you are ready to go onto a cadaver and start, using your scope. The day you do 2, 3 cadaveric workshops, I think you can easily start on your patient.
I think I can completely agree with you. You have to remember the Taj Mahal was not built in one day.
Absolutely.
Similarly, you cannot do endoscopic surgery like Sambhav Saab without going all the steps which he has taken. And what you see here is just the tip of the iceberg. The base is somewhere down deep in the ocean, and that is how you build your journey. So Vishal, what you have been a tubular guy, you do everything tubes, you are champion to. Do you think still endoscopy has a future? Is it the real future, or you still believe no? Tubes is the versatile. This is the gold standard today.
Only a fool will stick to one procedure. I'm going through the initial training phase again for interlaminar endoscopy. I've already abandoned two cases in the past 3 months where I had switched back to a tube, like Sambhav was saying, because of issues. But I mean, see, it's like a car or a TV. You don't use the TV what you had 25 years For that matter, every year they come up, but every 5 years, there's a 5-year rule in a car where it undergoes a complete technology shift. So if you're changing your car, you have to expect that technology will change your surgery too. So I trained in the early 90s, which was an open era. And now I'm practicing in the early 20s, which is completely the future is endoscopic. So you can't wish away my tubular surgery, but majority of the stuff will be possible through endoscopes. And as more and more people do it, it's going to get cheaper and more than, and it's like a procedure like UBE is like a natural step up for an open surgeon. He just has to get used to the 2D vision that you see in the screen. And with 3D scopes coming in, even that will go away. But you have to train with everything.
So, again, someone who has done all the steps and still willing to learn. That is what the spine surgery is all about. Even if you are a good open surgeon, you should try to become a equally good tubular surgeon. Once you become a good tubular surgeon, you can inspire to become a good endoscopy surgeon. Evolving, learning, and keep evolving is all it takes. And not to give up. I think that what Sambhav was talking about. Never give up. You continue to thrive and pursue and keep doing, keep failing, but keep learning. If you keep learning, you will reach someday, if not today, tomorrow. So Sambhav, thank you so much. I know you have some commitments, and thank you for giving us time. Yeah, Vishal,
Thank you.
I
something.
want to say one thing here, I used to other thing like what Sambhav said, that he doesn't sell endoscopy, he just says, I'm going to do a discectomy. Every surgeon has to remember to do what is best in his hands. That does not exclude him for not learning new techniques. He has to invest time and effort into that. But he should not do what he cannot do. Like today, if you ask me to do a complete endoscopic fusion, I will not be able to do. I just do my full endoscopy, decompression, and discectomies. But then if I don't do them, I'll never reach the step of doing an endoscopic fusion. Similarly, if you're not well trained, don't go there just because the market demands it. You'll fail and that would be a mess. And then you'll never go back to doing that technique again because that creates fear. Inadequate training creates fear.
So thank you, and Sambhav will let you go, and thank you. Always a pleasure.
Sure.
And okay, so
You.
yeah. So we kept the best for the last, and so we have now the master in MIS and tubes, Dr. Vishal Settiwar, and he will tell us the role of MIS in fusion surgeries. Over to you, Vishal.
Thank you, Ayush, for your kind words. I don't think I am that big of a master. Just give me 1 minute.
Yeah, please take your time. No worries.
Hi, good afternoon. It's been a long session. Everybody is either logged out or wanting to go and have their lunch. So the role of MIS in fusion surgeries. So microendoscopic. So this is a case. This was in 2007 or 8. Well, this is one of our first few cases, a simple case of instability that you can see here. And that's what we did for him. It was those days where I used to use a drain with my surgeries. This is a Sexton 2 system. And this was done through this small incisions. Way back in 2007 and 8, this was considered to be very, very unique and a lot of people were antagonistic to these surgeries. I think Vikas, me, and Arvind were the only 3 guys at that time doing this. 2007 and 6 fusions. Well, but the whole logic of the using a tubular surgery for fusion, minimal access, was if this is an open surgery, and that's how much your retractor will retract, your vision is limited to this much area in the spine. However, if you just go by the side, your vision is enhanced where you get to see the corners. And if you want to see this corner, you can still dock your tube from the other side. So it's just by going to the side that the vision comes out much better. Is it safe? Way back 2005 to 2010 literature showed it was very, very safe. The current literature is now, the recommendation is that tubular fusion is the gold standard when it comes to getting the surgeries done. Wrong level surgeries are practically impossible compared to what open surgeries could be. Tissue damage is much lesser. Cosmetically, they're better. Hospitalization is less. Infection rates are practically negative. Now we have close to 2,500 TLIFs done in the past 18 years. And we, like the previous speaker said, we don't have a single infection. The neurodeficit rates are extremely low. I had, in fact, one of my first deficits this year. It was an injury to the nerve root that happened. So that is like 1 in 2,500. So that's how rare it is. You can do multiple level cases. There is no need to discontinue blood thinners. Arvind has published this paper about 7 years back. And since then, we've stopped discontinuing blood thinners doing the surgery because the primary blood loss is so little, 50 to 100 cc, that even if you have a blood thinner going on, the blood loss will increase to maybe 150, 200 cc, which is much less compared to what an open surgery blood loss would be. And with there were fears of radiation exposure, which are very, very legitimate. However, with modern navigation, those have also become redundant. So just to illustrate, this is like a 75-year-old high-grade listhesis on methotrexate for 2 decades and bedridden because of high-grade listhesis. She came only because she couldn't go to the bathroom. This is what we did for her. And that's her sitting and squatting at a month. These activities may sound strange to foreigners, but to Indians, these are two things that they want to do in their activities of daily living. And open surgery, also this is possible, but not so soon. So this is how safe and stable your surgery can be. This is a case we have done 10 years back. A high-grade listhesis is severely diabetic. You can see how fat the patient is. There is more than 8 centimeters of subcutaneous fat there. And that's what was done. These are Indian implants from Jesco company. And that's the fusion mass at the end of about 2 years. She's still continuing to walk very well and has had her knees replaced since then. This is another surgery we did as a demo surgery for BSS Con in KEM hospital. And that's what we could achieve a correction. This is a 19-year-old lady. Over-the-top decompressions, people fear. Can we see this? This video is from 2009. You can see how clearly and how cleanly you can see the opposite fragment, opposite foramen, and you're able to do your decompressions well. So in navigation, again, people, the radiation limit, this is how easy it is now to pass the percutaneous screw. This is the what you see on the screen. And this is what I'm doing. This is what is virtually been projected to me. When I reach the deep fascia, in fact, you can feel every giveaway that you give in 3 dimensions. You can measure the length of the screw that you're going to put in. This is an OARM-based navigation. You know exactly the length of the screw that's going to go in. You know the thickness. You know where it is going with fair accuracy. There is hardly any radiation except for the one CT that you take to feed the navigation when you're standing outside. Compared to a continuous fluoroscopy use that would have happened. And that's how easy it gets. It also allows you to use anatomical landmarks and anomalies to your advantage. As you can see here, this is an osteophyte. Osteophytes don't disappear after surgery. They remain there, especially at alpha S1 level where you need a more secure tricortical hold. So this navigation allowed me to drill through this osteophyte and put in my screw there, so giving it a more secure fixation. This case of a high-grade listhesis in a revision scenario. That's the X-ray representation. That's the patient's MRI and pre-op X-ray. That's the post-op X-ray, and you can see how small the incisions are. But the best part is that's the blood loss that the patient had for a redo surgery. Is it worth it? I definitely feel so. A redo surgery is particularly messy, and doing it via tubes makes it much, much better. So multiple levels, that's also possible. This is a lady who was our mother of a doctor who works at Kokilaben Ambani Hospital, is a cardiac anesthetist. And that's what we did with an MIS TLIF at 2 levels. This surgery is now already 5 years old and she's doing very well with that. This is another 65-year-old who recently had 3 stents put in his heart, came with a bilateral flail foot, and that was what was done for her, done for him. He is still yet to recover. It's about 6 months from the surgery. The foot drop has improved, but not completely recovered, but his pain is gone and is able to ambulate. This we did with his antiplatelet agents going on because of his recent angioplasty, and an open surgery here would have been a disaster. This is another one. This is an osteopetrosis case. This was done for 4 levels. We didn't this is 8 years back. I didn't use S2 ilium screw here. We had an implant failure. Fortunately, the patient's L5S1 did unite, and he plays his round of golf every day for the past 7 years. That this is now near 2017 surgery, so the 7th, 8th year post-op, and he does go out for his round of golf every day. That's a case about 10 years back. That's a bad Anderson's lesion in an 82-year-old, ejection fraction 25% odd. And that's what was done for this. Is Medtronic's longitude 1 system, and that's what we managed for him. This person lived for about 10 months post-op, but he was walking around the quality, I think a year plus post-op. But he was ambulant. He was bedridden prior to this for nearly 3 to 6 months. So, and very happy that he could walk around and be mobile with that. Well, the advantages of MIS are there. However, when there is a law of diminishing returns, if the more levels you do, the posterior approach can create some problems. That's where the oblique approaches come in. This is a case of multi-level adjacent level disease where you go in obliquely, the oblique lateral effect, and that's the post-op X-ray. That's the restoration of the lordosis that can happen. This is another patient is a 14-year-old still growing child. You can see the research is not completely the iliac apophysis is still there, and he had fallen down. This was a burst fracture. So this we incorporated both the posterior as well as the lateral corridors of this patient. So what you can see here is the tubular, you can see the dura is completely tattered, and that's the retropulse fragment here. So I'm using a punch, and what I'm holding here is a navigation pointer. So I know where my retropulse fragment is, and I'm using that punch to push it away inside. With this kind of dural injury, and this patient, if you can see here, is fairly obese. With this kind of dural injury, if you do an open surgery, the leak and the morbidity that would have been bad. We would have had to go 2 levels up and down. So once we push down the retropulse fragment, we put in percutaneous screws to hold it. And then this person had his board exams. He gave his board exams, and after his board exams were done, we went from the side. You can see this in an interbody cage. The plan was to put interbody cage, but there was a complete non-union here. So what we did instead was we put in, went in laterally, took out the disc, did a corpectomy, and put in this cage with BMP, and that's his image. 3 months post-op, this guy has now gone back to his studies. So, well, is it safe? It is safe, but what do you need to worry about? So when you put in percutaneous screws, which is an essential part of fusion in the spine, you have to remember when you do it with using a fluoroscopy, there's a 13% chance that it will go out, and more about 4 to 5% will have severe violations of the pedicle. So you need to be very, very careful. These violations are more common on the left side in right-handed surgeons, because we tend not to give the obliquity while putting it from the side we usually use. And that is more common in the left S1 pedicle and the higher lumbar pedicles because of the anatomy that is there. Well, navigated screw fortunately have a lesser chance of going out, and none of them needed to be revised because there was no neurological deficit. This is the study I'm quoting here for this. Well, other complications, a lot of brouhaha has been made about XLIF and OLIF complications. Yes, they are there, but then there's no surgery that does not have a complication. So you should be very judicious about what you pick up for, and you have to be vigilant about what you're doing. OLIF is much better than an XLIF because the severe neurological complications are lesser. However, the vascular complications are much more in an OLIF, and the opposite side fragment causing opposite side stenosis is much more common in an OLIF compared to an XLIF. Decompression has to be indirect, so sometimes there might be residual stenosis. Permanent weaknesses have been seen in about 1 to 2% patients, which is a very, very high level of neurodeficit. So we reserve this for very, very selected. So I think Ranjit and Amit Jhala went together for our OLIF training way back. With a lot of enthusiasm, we started doing it. And then I kind of lost some of my enthusiasm for it as we saw things not going as per what was being sold. However, this is a brilliant surgery for and a very powerful tool to correct deformities, and is very quick. The blood loss is very, very less. Of course, it cannot be done without having an access vascular surgeon on the standby, because if there's something goes wrong, it shouldn't be that you didn't have anybody to bail you out. Well, other than that, MIS is, in my opinion, a very, very safe and effective surgery. That is what is going to be today of the surgery. It is what is going to be tomorrow of surgery. There is an issue of investment in technology. I mean, any spine surgery is not cheap. You'll have to invest in technology. I would rather be having all my armamentum in the OT than driving a fancy car. So I remember this debate where Arvind and I were on the MIS side, and there were other very, very big luminaries on the open side. And Arvind been told that, Array, you've come in 800 and you've come in an Indica. Look, I'm coming in a Merc. And then Arvind had put this nice slide of a bullock cart and a Ferrari. It's like when I come from my house to my hospital, I come maybe in a Maruti or a Indica. But when I'm in the hospital OT, I'm driving a Ferrari. I would rather drive that Ferrari for 8 hours in the OT than drive the Indica in my, and then use a low-tech option in the OT. So I always feel, I personally bought a house nearly after 2 decades because I ended up investing in technology, and it is something that you have to do as a surgeon. You are a surgeon who's operating. You should have your own tools. You should not expect that the hospital will give you everything. Of course, there are some tools like a microscope that you cannot buy, but I have everything that I use in my surgery is mine because I know what I can do. It also tells me what I cannot do. That makes surgery in my hands safer, in my opinion. To have everything you want, you're your own standby. There is no collaborate, have all the proper technology and learn. Don't be impatient. You cannot learn this in a day. We are still learning. I did my first MIS TLIF in 2007. I did my first MIS decompression in 2003, and we are still learning. There are always cases that give us a setback once in a while, but that's how life is. It's not that other surgical techniques don't have complication, but in MIS, the complications are lesser and probably a little easier to manage. Thank you very much for the patient hearing.
Thank you, Vishal, and it's always a pleasure to to listen and to learn from experience. Now you have gone through the whole cycle, and now you are there where you can really do the next level of MIS fusion, and that is what you have shown. And again, we are talking about you learning another technique. So what do you think? How will this pan out for you? Now, I know that you can really do even the most complex cases of MIS fusion using a tube. Where do you see it will lead you once you start using your endoscopies?
So, see, I had a young scope in 2006. Sushruth was a dealer for Wolf, and we had the Vice scope at that time. Like Abhijit said, unfortunately, the first few cases went off very well. We are all very gung-ho. And suddenly I had 3 cases where the disc reherniated. and patients were unhappy. That's when I took my first break again in middle of this to learn the techniques again, where I realized probably tubular was better because transforaminal was not the answer for everything. Now I'm doing tubular surgeries for nearly 2 decades now, and we've done few of them. It is a good thing. I had actually entered my comfort zone. Okay, this is it. This is what I am going to do. But that's never a good thing for a surgeon. The moment you get into a comfort zone, that's when you become a dinosaur. You have to evolve with time. The future, see, microscopes have become horrendously expensive. A good quality microscope can set you back by nearly as we got a new Kinevo with exoscope, and it's very freakishly expensive. But the same thing is with we have a Revo system for monoportal endoscopy, and that is also fantastically expensive. So the cost is the biggest limiting factor for wider assimilation. Fortunately, with localization and globalization of available of resources. Now, just before this talk, my fellow who was with us, who is now a consultant in Bangalore, Dr. Srinidhi, he does his UBE. He's got a simple 35,000 0-degree scope, and he's collaborated with an arthroscopist who already has his own infrastructure, and that's where he is doing his surgeries. So you have to be smart about how you acquire. Cost will come down as technology expands. So I think the future belongs to majority of the simple jobs will be endoscopy, because it is widely available and it is available everywhere and it's portable. So you go to a tier 3 or tier 4 town, you will still get an arthroscope. If not an arthroscope, you'll get a laparoscopy set up with a general surgeon where you just have to add a few things and you'll be able to do it. Of monoportal versus UBE, I think UBE will be more popular, if not less traumatic compared to monoportal, just because of the costs and the investments that have to be made. And the learning curve for UBE is much lesser. When we tried our hand, UBE was much easier compared to a monoportal. But endoscopy with memory metals coming in, with advanced robotics and all, I think the need of a microscope is going to be less and less and less with 3D endoscopes coming in. Neurosurgeons already use endoscopes to get their pituitary tumors and all out. For them also, it's not going to be a very... and other advantage of a scope is the eye is at the tip of the scope. So you are actually seeing it inside where the canal is, unlike a microscope where the eye is still outside. So future is endoscopic. I feel the future is endoscopic. However, we haven't addressed certain things like restoration of the lordosis in an endoscopy is going to be a challenge. Multiple levels is okay. See, I mean, even when we started TLIF, probably multiple levels was a difficulty. Over a period of time, multiple levels may get better. But the biggest challenge is going to put adequate size cages. With a stenoscope, which is about 10 millimeters, a 10 millimeter scope working channel cannot take in a cage that is large enough. So you have to make a separate channel. Then you're going to use expandable cages. Any instrument that is expandable is inherently weak. The graft sources are going to be complex. So there are a lot of issues. I'm sure in future we will be able to go over them, but probably another 5 to 10 years. And microscope, I wouldn't invest in Carl Zeiss anymore. Because if you see the new Zeiss microscope, Tivato has a small endoscope that they have incorporated with that, so that you can see better inside. So essentially what they're saying is, okay, we are a microscope company, but we kind of incorporated an endoscope, so you can still use our microscope and endoscope together. So future is endoscopy. The moment we figure out how to do an intradural tumor, it's just a matter of keeping your fluid pressure such that it doesn't go too much into the intradural space. If that is sorted, intradural tumors, I think there are a lot of Professor Park in Korea is already doing his intradural work using UBE. So I think the future is scopy. You jumped into the bandwagon at the correct time, switching from tube to scopy. I'm following you here.
No, so thank you. I sort of completely agree with you. I think and I agree that future is endoscopy, but maybe some parts of endoscopy in terms of technology, when it comes to fusion, we are not yet there. But it is the right time for anyone who wants to become an MIS surgeon to follow some sort of endoscopy, whether you can do UB or full endoscopy. Just a matter of money, what you can afford. But it's better to have a car than to have a bicycle. So at least it's a car. And as we go ahead, the cost of implant is coming down, the cost of equipment is coming down, the technology is getting better. Even I have my reservations for uh, endoscopic fusion as of today, and I have only tried one or two, and that is where I am. So the jury is out there when it comes to endoscopic fusion. But if you have to do a simple disc and I have to choose between a tubes endoscopy, I think endoscopy is a much better approach. Nothing has changed, as we have all been talking about. The basic principle of a spine surgery has never changed, whether it's open, whether you do tubes, or whether you do endoscopy. The decompression has to be precise, the discectomy has to be adequate, the restoration of balance has to be done. It doesn't matter. What only you are changing is approach to that surgery. And the lesser the approach, the better it is, because it's more physiologically, it is more beautiful. So it cannot, so that's all we are talking about. And if your basic principle, you need to learn, you need to master, you need to understand. The most important thing is the diagnosis and the decision to operate and what to do. Rest, everything sort of follows through. If we don't have any comments, we are already, on the verge of the time. So any parting comments from ICOB, anything you want to just say or suggest? ICOB, you are there.
Thank you. Yeah, first of all, thank you. It's for me a very, very big experience to be here, to have this type of experience, to listen to this type of experience from you. And thank you again. Thank you again. I think I agree with you, colleagues, with Vishal, that future is for endoscope. I think also I'm trying to start tubular removing of tumors, spinal tumor. I think it's possible. Main problem is how to close dura, and it's if you can deal to close very very closely to avoid CSF leak. I think I can do in future spinal tumor removing through the tube, and also endoscope. Endoscope is I think for posterior cervical, endoscope is the best. It's just my personal things. Because you can preserve muscle, and muscle is most important in the cervical than lumbar, I think, because of pain, because of physiology, and for cervical, endoscopy will be future, I think, more important.
Vishal, any parting words?
Yeah,
again.
so actually tubular tumors can be very easily taken out using a tube. We used to do a lot of meningioma excisions with our neurosurgery colleagues, and we still do that. And for closure, what you need, there are specific dura closure sets that you get. But the easiest way to use and the cheapest way to do closure with a 5 or a 6O proline is to either use bayoneted blunt forceps to adsense to hold the needle and go through, or you take a solid 1 millimeter disc forceps that goes in. Your hand is outside the area of the tube. They are also up and back-ended, so you can use an up-ended one. Go to the corner, dip it, leave it, then grasp your needle and take it out. And then you not pusher or the shoulder surgery. There's something like that. You devise a T-shaped, or you can use a ball tip and get the knot down. But the easiest way to do it is to use a ligature. Just approximate your ends and fire a ligature. So with this vascular clip, but that's what you use to clip veins and all. You can just put a couple of them and then seal it off. It's the easiest way to do it. We no longer suture our repairs. We just use ligature and that's it. And that's again something I learned from my neurosurgery colleague Abhay Kumar, that instead of I used to suture, it used to be tedious, it would take an hour. We just use ligature to fire and it does that. And we have in fact done calcified meningiomas at D6-7 level and D8-9 levels, and they have done very well.
So I think with this, we have really
Completely
run
agree.
out of time. And we have anyone from Bombay BOS for the parting words? Yeah.
No questions.
Okay, nothing. Okay. So thank you everyone. And it was a pleasure and honor to be among all the experts. And for all the participants, this is just a trailer. If you really want to see the full picture, do join us at the WIROC, which is going to be one of the biggest event in Bombay. And even for going further, if you want to know about specifically more about MIS, we will be doing one of the biggest spine meeting later in 2025 in Mumbai, so which is ASMIS AP. But this is all about WIROC. So we this was just a curtain raiser for WIROC. Let me thank all my panelists, my chairperson Vishal and Arvind, and Aikov, who joined us from Georgia, and even the others like Avjit was there, and we also had for endoscopy one of the best speakers which we have in India. So we sort of in precise 2 hours we have tried to fit in whatever we could. It's a learning process. It's not just that you listen to one webinar or you attend one meeting and you can learn MIS surgery. But if you really want to do it the way ICOP just showed us, if you have the courage, if you have the wisdom, if you have that will of not giving it up, you can become a MIS surgeon. Thank you. Thank you so much.
Thank you.
I stop the
Thank
live
you.
streaming.
Thank you.